So we're talking today about consumerism in healthcare. And I didn't get a theme song, but if we'd gotten a theme song, I would say that for healthcare these days, it's complicated. And we talk a lot about consumers wanting choice and how having competition makes it great for consumers. Last week I was talking to a gentleman who's 64, and it turns out insurers really need you, want you, and desire you tremendously when you're 64 to sign you up for Medicare Advantage. And he has this high-class problem. Never had to deal with signing up for insurance. He was always on his wife's plan. And he says, all of a sudden, all these people are coming out of the woodwork to contact me. There are just so many choices, which is what everyone complains about in healthcare, that we don't have enough choice. So let's talk about how each of your approaches is looking at this problem for consumers. On the one hand, in some places, they don't have access, they don't have choice. And on the other hand, they get overwhelmed because there's just so much to figure out. Dr. Dwell, what was the impetus behind HEAL and creating these Medicare practices that really try to address that?
I'll start by explaining that what we've built at HEAL is an app that allows physicians to deliver house calls. And so what happened was very personal to me, and it wasn't, in fact, a Medicare type experience. It was me being a patient, my children being patients, and the confusion I had, and I'm a physician, I couldn't figure out where to go to get access. I had to go to an emergency room instead of a clinic setting or instead of waiting at home. I couldn't understand the EOBs and the hundreds of thousands of dollars I was being asked to spend. I couldn't find the right doctors. I couldn't find the right specialists. And on one of these drives home from these horrific experiences, my husband and I had a conversation around how a lot of confusion just needs to get out of the way. And what we really wanted to focus on is physician and patient and working through that relationship, or physician and guardian to help patient. And that's a lot about what we focus on, to your point, removing the confusion.
And Jack, I feel like we are kindred spirits since we're the only two that are not doctors here. It's kind of,
we won't hold it against
kind of nice. Everybody else is so much more qualified, I guess, in some ways. You founded Take Command Health, and payers, health insurers these days are demonized. People want to actually ban them in some cases, that we shouldn't have private health insurers. What made you decide to start this new kind of health insurance company?
Yeah, thanks for having me. And as the non-doctor here, my journey into healthcare really was as a concerned consumer. Thankfully, it was a good story. My wife and I were blessed, but a little surprised with twins in graduate school. And there's a funny story where I had gone to the loan office a few days prior and thought I was just taking out loans for tuition, and then had to go back a few days later and say, I'm going to need a lot more money because I've got twins coming. So
we're going to need a bigger boat.
We're going to need a lot bigger, a lot more. So thankfully for me, it was a good reason to need to engage the health system, but frustrating at the same time, because here I am trying to figure out how it works, and I need to plan and budget for twins, and I couldn't do it. So Take Command Health actually started as a consumer advocacy tool. Now we help a lot of employers set up defined contribution arrangements, and then we connect employees who are receiving those arrangements to health plans and services to help them spend it wisely, really to try to empower them to be smart consumers. But I think the key takeaway that a lot of times we might forget in the healthcare system is a lot of times the patient's journey, their consumer journey, it doesn't start when they knock on the door or when they open their app. It could. A lot of times it's when they're choosing an insurance plan for the year, and they may not connect how that's going to impact them later down the road when they need services like HEAL, or they need access to one of the great hospital systems.
One of the things that people talk a lot about now, and I want to put this to Jaywon and Adam, is that things work best when the provider takes some risk. All of our new models from the payer side, from the system side, is sort of saying, look, if you get doctors to take some risk and get some of the reward for keeping patients healthier, that works better for the system. Does that work better for patients as well? Because we're talking about the consumer experience. So if I'm a consumer, when I go to do a Cleveland clinic, community clinic, how am I better off because my doctor is taking more risk?
Yeah, it's a great question. I'll take it back to what patients really, as we study it, want out of their healthcare encounter. They want to be heard and understood. They want to understand their own clinical situation and what is being offered up to them as choices about their healthcare decisions. And they want to feel like they're being cared for by a team of providers that are on the same page. So that's one thing that they want out of healthcare, and I'm getting to your answer. The other thing that is very clear is they want that to be convenient, they want it to be inexpensive, and they want it to be high quality. Now that's a lot to deliver on, but nonetheless, it's very basic stuff that I feel very confident that we can provide. Now, we haven't done that very well in healthcare in the United States historically. We've been typically very transactional in the way that we manage health. A patient presents with a chief complaint. We provide the service for that chief complaint in return for a fee, and then we part our ways, and then hopefully that experience was positive enough that they'll come back for their next transaction. There's a real change right now, and some of that is being led by the shift toward value and the shift toward us taking risk. That real change is toward us emphasizing not transactions, but rather a relationship with the patients, more of a longitudinal, prospective relationship that says, what can we do to partner with you to inform, activate, and resource you to be a full participant in impacting your own health long-term and longitudinally. Because frankly, just about 20-30% of a person's health outcomes are really determined by the discrete health care that we provide. 70-80% of it has to do with other determinants of health that may not directly be in our control. So partnering with people to define what those might be for them is really, really important. Now, the way that risk helps us is it changes the payment paradigm to where we are incented, bought into the concept of being that partner rather than just emphasizing the transaction. And I think that, at least in part, is one of the ways that changing the payment paradigm can change the patient experience in a better way.
J1, obviously Geisinger is also an integrated health system. So this change, in some ways, isn't that what you've been doing all along, or are you also changing?
Yeah, no, I think that's right. Some of it has been exactly what we've been doing over really many decades. If you think about Geisinger, half of what we do, think of it as firmly in the value world and in fact, complete risk. The other half still in sort of fee-for-service world, but getting to your question of how does the patient benefit, I think it allows us to build programs that make health easier. And it dovetails into the earlier question around consumerism in healthcare. We think that when you make health easier, because of all the complexities that you alluded to, I think people's health improves, and that becomes possible when we're in that risk arrangement. I'll give you a few illustrative examples. We have our fresh food pharmacy program that's now tripling in size this year, targeting diabetics who are having a tough time managing their disease and people who are also food insecure at the same time. And through that program, we've demonstrated that the effects of that on them managing their disease is double the impact of what traditional medications yield. And
So
so
you
food
actually get-
truly is better than medicine, and
You
that's an
get
example.
prescribed some kale and beets. And
We prescribe them to join the
which to
program.
my husband, I would
and they
say,
have-
is,
yeah.
it's like, why are you being so cruel to me when you give me kale?
They get access to fresh produce, lean meats, but more importantly, the coaching, the nutritional support, the dietitians, the social workers, and sort of a wraparound set of services that ends up really yielding that impact. And again, if you look at engagement levels, they go up, ER rates go down, admission rates go down, and the diabetes itself is better managed. Similar to what we've done in primary care, we've invested in smaller panel sizes, longer visits, and when we've done that, we've taken 15% off of hospital admission rates, making health easier because the clinic, and primary care in particular, is easier than the hospital. And then the last example would be our Geisinger at Home program, which takes the sickest 5% of our patient population, does home visits and IV medications and point of care testing and diagnostics in the home. And when we've done that, we've seen 45% drops in ER levels and hospital admission levels, the home being easier than the hospital. And so with each of these programs, I think the theme has been making health easier by substituting food for medicine or home for hospital. And that's sort of the philosophy on which everything's been built.
And how does this whole new emphasis on home translate? Is it really about just certain populations? Because somehow we hear oftentimes that it's sort of everyone wants a virtual care. Everyone wants, to be able to drop in for a visit and on demand. And I'm not sure that, my millennial friends want the same thing that I want, and I don't necessarily want the same thing that I want for my 83-year-old mother who does have chronic conditions.
Well, I think what you bring up is a great point. It's about trying to understand the consumer, understand your patients, and understand what their felt needs are, and then trying to meet them. One of the ways that we do that is each one of our primary care service areas, we have focus groups where we bring together patients and families to listen to them and say, what are your respective needs in this community?
And what are they telling you?
Where do they?
And what are they telling you?
What they tell us, it depends on the community. Some of them say, I want access when I want it. I want access at home where I want it. Some people say, I want to be able to call and get you on one ring. Some people say, I'd like to have you come and see me in my home. And so what we've done is we've built a variety of different programs to do just what you've described there. We have changed, and one of the ways that we changed the payment paradigm, when I started here about 16 months ago, 0% of our primary care reimbursement was in what would be called capitation, or a guaranteed payment model, where you get paid ahead of time per member per month. By the end of this year, we will have transitioned to 50% of our primary care will be in capitation, and by the end of this next year, 70%. And so what that does is really decouples us from the traditional fee-for-service flywheel of sorts, and allows us to provide care in ways that may not be directly compensable, but meet those felt needs of the patients for home care, for virtual care that may or may not be otherwise reimbursed.
But if I'm a consumer, and I know you guys are in it for my health, but at the same time you're also businesses, why shouldn't I be worried that when you get a certain amount, you're going to cap how much care I get? One of the reasons HMO got a bad name was because it was about capitation. And as a system, we need to capitate because you can't have people just spending and we can't continue to spend. But as an individual, of course, I don't want to be capitated.
Right. The first iterations of HMOs didn't really focus much at all on quality or the patient experience. Each and every one of the contractual arrangements now focuses equally on quality, patient experience, and the spend as well. So it's a different iteration of it now.
I think we keep calling them consumers. You're not a consumer, you're a patient. And by definition, the physicians or the folks on this platform, for example, who want to make sure you get comprehensive quality care have an ethical responsibility to make sure you get what you need. In the home, we don't even have to ask questions. We can see. You're an asthmatic, there are dust mites. You might not have access to fruits and vegetables. We can enroll you in a program to help, right? So it's really about looking at the patient and giving the physician or the provider the sense of ownership that, okay, I'm here now, here are the 5 things that I need to start doing. And then coordinating that relationship. It's funny, in this whole business of on-demand and software, I sometimes get asked, well, what's going to happen? Are you going to disconnect? Are you going to use hubs and monitor your patients and never come back? And in fact, no. When we're in the house, it's as intimate as can be, right? And we're coordinating care for our patients even when we're not there, right? Using software. So that's, I think, what all of us on this platform are really studying, is how to get closer to our patients and help them with what is necessary without overutilizing, but to ensure that they also are partaking in what's going on.
Dr. Dewey, you mentioned, empowering the physician, which I think is super important in these kind of models.
The doctor,
the doctors as well. Yeah, sorry, what I say, empowering the physician or the doctor. I think there is also to be something said about, the patient, empowering them as a consumer too, not to diagnose themselves. We don't want, patients, trying, reading on WebMD and coming up with their own diagnoses and things like that, but equipping them to ask the right questions.
Sometimes doing that research helps you to ask the correct questions.
They can ask the right questions, yeah, and I think that's the key thing. We work with a lot of clients, and a lot of them are brilliant accountants or attorneys or engineers, and they can run mathematical models, on all sorts of really intelligent things, but then you talk about healthcare and their eyes glaze over, and they don't know the difference between deductible and copay, or they don't ask, should I be getting this at home, or are there other ways to do this besides just showing up at the ER? And that's where providing a little bit more empowerment on the consumer, I think, would be really powerful too.
There was actually an article that came out this week in the Journal of the American Medical Association that raised the question, are people patients or are they consumers? And it's actually a fascinating read, and the answer is yes. It depends on
the circumstance.
It depends on the circumstance. If it is, I need a flu shot,
right,
or I need, I need a sports physical done, they're a consumer. They're looking for the most convenient way to get that need met, where they want it, how they want it, when they want it. And yes, so very clearly they are. But for the continuity of care, chronic care, investing in a lifetime of care, they want to make patient-oriented decisions informed by a consumer approach. And it's kind of an interesting read if you haven't seen it.
It does seem, in terms of urgent care, at least, I know that I'm probably a little jaded because I live in a big city where we have a lot of different options, and obviously covering healthcare, I see that there are a lot of options in a lot of locations. But when it does come to patient care, even in this consumer age, it's so hard to navigate. You're focusing on pediatrics and on the Medicare population. And I want to focus on that because that is one of the areas where we are seeing more innovation. Mm-hmm. But it seems to be one of the areas where there is just so much need because people have so many chronic conditions, and that's where they are patients.
Yes.
And it's hard. I mean, I can say it as a caregiver trying to navigate with my mom. Her doctors are not in the same hospital system, but those are the two that are closest to her and convenient, and it's easy to communicate with them. Even within the hospital systems that they are affiliated with, they aren't on those hospital systems' EMRs. So, try doing a blue button. I still can't get all of her data. Mm-hmm. So, and I'm fairly sophisticated in trying to get all that data together. Yep. I don't know if it were my brother who can barely operate his mobile phone, if he were in charge, whether he could.
Yeah, and I mean, I think it's a very important conversation about gearing an experience to a caretaker. And that's why we focus on these vulnerable populations, the kids and the seniors, because, you know, people have asked me, well, Renee, how would a senior use an iPhone? Well, you'd be surprised.
Some of them are, yeah.
Many that we interact with are very tech savvy. On the other hand, our company will forever have an 800 number, right? Because we know that there are parts of our populations that must call, must ask questions, and maybe have a mistrust of someone coming into their home. It's really about how you design the product, right? And how you allow the product to be used. By the same point you're making, one of the things that keeps me up at night is overutilization, fracturing care. We are not an urgent care on wheels, right? This business of delivering a flu shot is ridiculous. We do it because we want people to have their flu shots. On the other hand, it's cost intensive, resource intensive, and unnecessary. But it's a
But if you have someone who's not necessarily the most mobile.
There you go. But
And
even
you
those that are mobile are doing it, of course, right? And I want to make sure that if we're not the PCP, then their PCP is informed, right? So I want to make sure that we're all communicating and collaborating, and our platform is working very hard to do that. But to the point of patients being consumers, many times patients, it's like they're cheating on their doctor. No, I don't want you letting my PCP know that I work with you, you know? So there's a huge conversation happening here about who to gear products for and how to do it safely and economically, and deal with those who really do need that continuity of care piece the most, how to focus on them.
As we look down the road, now that we do have the ability for people to, you know, I fortunately, my doctor is within a health system that through FHIR, I've got all my records in my phone. It's not like I have a ton, but, you know, I can have them and I can be organized about it. And, you know, my husband would say I'm just OCD about everything, but I like knowing that I have it at hand. How does that sort of look as we move out to the future? So, you know, I will have all these records when I go into Medicare. I can bring them with me, and as I, you know, maybe in another 20, 30 years, if I start suffering from chronic conditions, there will be that nice longitudinal look back that I am assuming is helpful to a doctor.
Yes, absolutely. And that's the software we build, right? Our software allows the patient's profile to maintain in the patient app. The guardian can create all the, you know, accounts for the dependents. For example, for me, I have my records. We can interact with Epic, right? So all my hospital records are in my patient app, my children's records, my partner's records, they're all in my patient app, and I can share them, right? So we've literally built software that considers exactly what you're saying, and it couldn't be easier to use, you know?
Does that bode well for the future to be able to make it easy?
I think, to your point, for example, if your brother is now entering a world where you have to have a bit tech savviness and he doesn't, at least you do, right? And you can help him access his records and share his records for his protection. Do I think the sharing of data is a very big and scary thing? You bet, you know? Have I myself been in situations as a physician with patients who have no idea what they're doing with me, no medication, no English? More often than not, right? So I find myself in a vulnerable position trying to help someone that can't help herself. So I think no matter how we swing it, software is going to help us solve these problems. Of course, we're going to protect patients' privacy. Of course, we're going to give them the ownership of their own information and allow them to protect it. That's how we think about it.
J1, obviously you all have within your system, I would imagine, one EMR, I would hope. How do you see things as we move forward? How do we move the needle forward to make this easier and to help people have that continuity?
Yeah, I think the portability of information is absolutely critical, albeit with the right protections and so forth. I think,
but it's hard, you know.
Oh, absolutely. I think this
people
speaks
still have
to,
binders full of. I have binders full of things.
Sure. this speaks to the importance, I think, of integration, because I think the more fragmented the care becomes, i.e. different players, different systems, different organizations kind of doing their part to try, all with the best of intentions, I do think that has the potential to introduce a lot of confusion. I know with a lot of, in particular, those that are 65 and older and are seniors, multiple chronic diseases, you know, they might have a care navigator from their insurance company, they might have a care navigator that's specifically for their diabetes, another one for their CHF, and all of these folks kind of trying to help manage the care, it becomes very confusing for those patients. So what we've approached and tried to do is try to make it as integrated as possible. So to the extent that there's care management on board from different disease states, from different organizations, we try to centralize it through one point of contact so that it's easier, again, for the patient.
What do you
and the
mean by
families.
one point of contact?
So
One
for example,
social worker or one caregiver?
So I'll give you an example. On our health plan side of the business, like most health plans, we have care navigators. And then on the clinical enterprise side, whether it's the hospital or the clinic, we also have our own care navigators. We housed all of them under a single organizational structure so that it's one leadership, one team on point, and it's a little easier to navigate who's on first for that patient so that they're not getting bombarded with 15 different calls, all trying to do the right thing. I think things like that, that power of integrating, you know, whether it's pharmacy, hospital, physician, insurance plan, and having that all behave in harmony becomes very, very important. And you know, obviously one way to do that is to house all of those within the same organization. We have some of that going on, but you're not going to do that everywhere. And to the extent you're working in partnership with each of those other actors that play a role, we found that to be tremendously impactful.
I would echo the importance and the complexity of what he just described. For example, across the Cleveland Clinic, we have one electronic medical record. But we have a larger network that is called a clinically integrated network of about 7,400 clinicians that is, we call our Quality Alliance. And that is an extended network of both employed and independent physicians that are in the respective communities where we have facilities and patients. Now, within that clinically integrated network, we have 53 different electronic medical records, 53. And so connecting that information in a meaningful way that allows for us to truly be clinically integrated is very difficult, very time-consuming, and very expensive. But it's important, and I think when we get to where we have a defined set of pieces of information that represent the patient record, and that is interoperable across multiple different electronic medical records and portable so that the patients can then carry that with them, patients/consumers can carry that with them, then I think that's when we start to get to the place where some of these difficulties begin to disappear.
I have a question from the audience here, and it's to you, but I'd put it to all of you, actually. What's the future vision for taking the palliative medical and hospice at home to the next step in the realm of advancement of virtual visits? Would that go against the personalized care that the person might receive or that they might receive as a vulnerable population? Can you do palliative care remotely, virtualized?
Yeah.
Well, we do it in a mixed way. For instance, we have identified about 4,000 very frail elderly patients that we do house calls on in Northeast Ohio region. And among those patients, we have them see a physician and then an advanced practice provider in alternating months in their home. We found that was very, very impactful for patients, but yet they tend to decline pretty suddenly at times without much warning. And we found that we were unable to respond as quickly with sending a physician out to those homes, and found that we were stuck sending an ambulance with a paramedic out there. And rather than doing that and then incurring the disruption for the patient, the expense associated with an ED visit, and the potential for an admission that might be unnecessary, we hired our own paramedics. And when those calls come in, we send a paramedic out, not with an ambulance, but with a kit bag full of equipment to assess the patient and an iPad. And virtually, we connect back to one of our physicians at home base that we call virtualists, that all they do are virtual visits of this type. And together, between the patient, the family, the paramedic in the home, and the virtualist, we've been able to keep those patients at home instead of sending them to the hospital 80% of the time. So we've avoided 80% of those visits to the ED and or the potential for admissions, tremendous savings. But along with that comes the relationship, again, back to being relational in healthcare rather than transactional.
That is one of the issues I find with virtual care.
Yes.
I find with virtual care and urgent care, the consumer aspect of it, when I know it's nothing, it's great, but sometimes when it's on the cusp, because there's not that relationship,
Correct. So
it feels like it's redundant.
Yeah, we found a way to create the relationship with some of it being on site and some of it being remote, that what we found, an unintended consequence of this arrangement, was that over time, about 15 to 20% of the patients that are enrolled in this become hospice enrolled and embrace palliative care because they feel cared for and there's the ability to have a longitudinal conversation. These conversations are not easy, and we don't do it very well in the United States, period. But because of this relational approach, we found that the uptake has been very good.
One of the things I'd be remiss not asking is we're having this debate in the United States, at least in the political realm, about whether or not we should continue with our private health insurance funding system or not, whether there should be a public option or not. You talk about other countries, and I'd love for you guys to weigh in. You're in the health insurance business, so I'm sure you're not pro getting rid of them altogether. But it speaks to the fact that people are not satisfied with the way things work, and they feel that they are just behind the 8 ball all the time.
There's an interesting anecdote, I think, to go along with that is, we talk a lot about, or you'll hear people say, oh, healthcare is broken. And the reality is it's not broken. It's functioning fully as intended. The problem is the model is not very good.
You mean this Frankenstein thing we put together?
Yeah, the Frankenstein thing is not very good. So, and I think when you start thinking about it that way, and it's easy as well, to kind of miss who the real enemy is of the healthcare system. Insurers blame doctors, and doctors blame insurers, and you can blame patients, and PBMs. Those are always the easy ones to blame because they're not here, right? But the reality is it's disease, and it's sickness, and it's unhealthiness, and I'm a firm believer that regardless kind of where political stuff goes. And all these innovative care models, really it does get back to empowering the consumer or the patient, as much as can be, to really be their own best advocate. And that's hard. That's a big mountain to climb. But I think when we can start, zeroing in on that and encouraging those kind of behaviors, the system will self-correct and fix itself. It'll be demanded.
Can these models move forward if we decide to go for Medicare for all? Do you think?
Yeah.
Do they have a role in Medicare for all, or do we have to start from scratch?
I would say they have a role in any payment model, really, because at the end of the day, if you're trying to deliver the best care for the best value, regardless of what the overall distribution channel of how the payment ends up hitting the care, I'd say that the care model still, all the things that we're talking about, whether it's in the home or primary care or relational models, I think all of those models still work and add value in any host of different payment models, as long as that risk component still lands back with the provider entities.
The other piece that I think is missing from healthcare, and I think you alluded to it and you did as well, missing from healthcare in the way that it's designed now is our primary focus has traditionally been on the treatment of disease rather than the promotion of health. And that's part of what differentiates our healthcare spend and our healthcare system in the United States compared to our international colleagues. They have spent much more time, energy, and resources upstream, focused on prevention, focused on all the determinants of health. No matter what our payment mechanism is as we move forward, we will not really move not just the cost curve, but the health curve of the United States unless we move upstream and focus on prevention and the creation of health rather than simply the treatment of disease.
Which leads to one of the questions from the audience, which is, aside from virtual care and on-demand type services, what other programs can be offered to treat chronic conditions in the community that are both profitable in a capitated model, but also high quality? Because at the end of the day, it has to be something that's sustainable, and if you're going to be adding all these extra services, that's going to bring in extra costs, isn't it?
It does.
Well, if you're substituting extra services, I think all of the models that we're talking about are high-touch models. They're high-intensity models. But if you're substituting those high-intensity, high-touch models, but they're in the home, in the community, in the clinic, as opposed to being in the ER and in the hospital, that's still a great trade-off that's going to bring a lot of value to patients, consumers,
It brings
members
value
of
to patients,
society.
but is that sustainable for the hospitals, or are hospitals already understanding that they need to shift away from that very high acute, high dollar?
And if the hospitals are in any kind of march towards value or taking risk themselves, then the incentives are all shared. So, that could be one way to get their engagement into these models and this transformation as well.
We created a Bluetooth-enabled hub. It plugs into the wall, it pairs with a glucometer or a blood pressure cuff or a pulse oximeter or a scale. Very simple to use. Patient is given instructions on how to use it, how often. The data uploads into our proprietary software. So doctor is en route to a house call and can view her patient's hub data. And rather than say, Mrs. Smith, we have a house call, she can cancel and do telemedicine and say, Mrs. Smith, your sugars look fantastic. I don't need to come, right? Or, Mr. Smith, I'm concerned, and let's book a house call. So at once, it allows us to be very thoughtful about coordinating care, but not overutilizing house calls. And so this is an example.
How does that change the way a doctor practices?
For them, they feel connected, right? For doctors, what we want is information. It's that same paradigm I told you. Patient shows up, no idea why they're there, no medications, none of this information. And there's also this component to telemedicine, right? This person on the other line you've never met who is going to give you a Z-Pack, maybe, right? That isn't really coordinated care. That's not a relationship. We use the hub to build on a relationship, and the doctors love it, It's very important to them, in fact. They feel very connected, and so do the patients.
So we have a couple of minutes left. As we look out, it feels like we've been talking about all of this for so long, but it feels like with people accepting virtual care more, we're in the early innings. Where do you see things moving along? Where will we be when we're in the 7th or 8th inning? Will we not have to have these discussions anymore?
I think we'll be having these discussions, but I think that where health happens will be at home, right? We will use the house for wellness, hospitalization, hospice, palliative care, fillers for all I know, right? It will be where we access care, and the hospital will become a place where you go when you need anesthesia, when you need emergency care, right? I absolutely think that the way that the cityscape is changing. You get your groceries delivered at home, you get your hair done at home, the pizza comes home. There's no reason to think that the best medical care can't come home.
And as a payer, is that a way to...
Yeah, I think, the innovation and the kind of home care or technology, it's a great enabler of relationships, right? And so I think to Dr. Dua's point, if we're, and I love that you're building the hub to build relationships, because I think that's the key to, getting better. If it can go the other way too, where, it's just fee for service faster, and we're probably getting off track at that point.
I'd say that the healthcare spend in the United States is currently unsustainable. We just can't sustain it any longer. the outcomes in aggregate are not desirable. And the experience that each one of us and people, writ large describe is unacceptable. So I really feel like unless we change the way that we're doing all of the above, we won't be able to afford seats in the bleachers to be present for the 7th and 8th inning. So it's time to change it now so that we can experience a little 7th inning stretch and then decide what we want to do for the remainder of the game.
Dr. Rood, last word to you.
Yeah, I think the site of care is inevitable that's got to change to make things easier. The other thing I'll touch on, the communication and the integration again. I think, so far virtual care has been a lot of to the patient, to the consumer. I think there's a lot of wide open opportunity around making it easier for providers and care teams to communicate with one another. And I think when they do that, I think that's another whole field of opportunity that'll open up.
Thank you all very much for your insights, and we're going to leave it at that. Thank you for your questions as well.
Thank you.